on the line today. And so what we'll do is look at interdisciplinary rounding at the bedside from a particular perspective of a hospital system and an organization that's been doing this, I think, pretty well for about 4.5, almost 5 years now. And so the brand of interdisciplinary rounding that I'll talk today about is something that we call structured interdisciplinary bedside rounds. So the learning objectives, you'll be able to list 4 features of structured interdisciplinary bedside rounds, and then you'll be able to list 3 common obstacles in implementing successful interdisciplinary bedside rounds, and hopefully also not just listing obstacles, but a solution for each of those obstacles. So let's get into it. I will probably use the word cyber several times today, just as the acronym for structured interdisciplinary bedside rounds. We'll use it as a noun and as a verb. And cyber and interdisciplinary rounds probably looks a lot like this. In fact, it does look a lot like this when you've got all the players at the bedside. So one of the things to emphasize here, I think, is that you really don't have to have a massive team. Sometimes you end up with a massive team at the bedside on weekdays, but as long as you have a patient in a bed, a bedside nurse, and a lead provider, maybe that's this person right here, and here's the nurse and here's the patient, you can do interdisciplinary rounding at the bedside. It's terrific to have, very nice to have a family member, and so sort of doing some internal marketing within the unit about what time rounding is going to happen is a great thing for families to be able to hear and be heard and be present. And then this may be an allied health professional, it could be a pharmacist, it could be a discharge planning professional. This is not a necessary but a really, really nice to have type of role here, which is sort of a second provider, really easy to have in a teaching environment, of course, and in some hospital medicine practices in a non-teaching environment. Perhaps this is a physician's assistant or a nurse practitioner, or maybe this is the attending, actually, right? Maybe this is the attending, and this person here talking is the physician's assistant. There's a certain amount of interchangeability depending on how these 2 providers divide up the patient census as to who might lead cyber for the interdisciplinary rounds. So just a very quick piece of context. We've been talking, this subcommittee has been talking also about geographic units, and we heard from Kevin and David at the last webinar on that topic. And the geographic unit that we've contextualized our version of interdisciplinary bedside rounding in is something that we call the accountable care unit. So we've defined that geographic unit, that ACU or accountable care unit, as a geographic inpatient care area consistently responsible for its outcomes, whether those are clinical, service, or cost outcomes. And that's the definition we've been using. There's, actually, before I move on and point you towards some reading on the topic, I want to call attention to a very common question that comes up. Hey, if you do interdisciplinary rounding at the bedside every day, and you do it in the morning, what sort of unintended consequences arise? And specifically, doesn't that make it hard to actually get your discharges written and processed and maybe even get a few folks out the door early in the morning? And it's easy to understand where that question comes from. In order to get ready for interdisciplinary rounds as a provider, you've got to do a significant amount of primary data gathering. You've got to examine your patient ahead of time. You can't do your physical exam while everybody's watching during the bedside. That's too many person minutes that lop off the clock while the physician gets their needs met. So yeah, it's a pretty intense morning. What about this issue of getting patients out the door? There's a significant imperative around that in many hospitals these days. And what I've done here is I've just taken a screenshot of our active bed management system, our bed view system, and I've sort of circled at the bottom right corner the time that the screenshot was taken, 9:35 in the morning. And you can count for yourself how many of the green and white striped rooms there are on that unit at that time of day. There are already 1, 2, 3, 4, 5 different active discharge orders. That's what the green and white stripe means, on the board by 9:35 in the morning. So the answer to the natural question, but doesn't this delay your discharges, actually ends up being no. It doesn't have to. So that's a little bit of a tangent, but let's keep moving. I have two disclosures to share with you. So one is I'm a founder of a 501c3 nonprofit called Centripetal, and through that have received fees for teaching hospitals, training hospitals to work together in high-functioning patient-centered teams. And Centripetal has done 75 or more trainings in the last couple of years at various hospitals. So that's an important disclosure. And another disclosure is that we recently created a new company called One Unit, which aims to help hospitals cost-effectively implement this geographic care model, ACUs, with structured interdisciplinary bedside rounds, and we do that through an implementation kit. So there is this commercial bias or potential conflict that you need to know about me as we kind of move through this presentation. Two things I'll point you towards in terms of reading material if you're looking for something after the webinar today. In November 2013, there was a nice piece published in the Harvard Business Review online blog called A Remedy for Fragmented Care that's accessible, and we had our paper describing the accountable care unit in cyber published in November 2014 online, and I think it came out in the print edition of last month's SHM, so I would point you to each of those two sources. So one of the reasons, backing up for a second, that we're even having to talk about this stuff in 2015 is that, well, the hospital is a complex place. It's a complex workplace. There may be a more complex workplace in industry or business, but I'm not sure I've heard any credible suggestions from anybody over the last couple of years about where those workplaces are. At any rate, the hospital is a pretty semi-chaotic, fairly complex place to work, and we haven't really paused long enough, even in hospital medicine, to think about adequately how we organize ourselves when we come to work every day. And I'll say something here which I believe is true, and that's that hospital medicine has primarily been a staffing model innovation in staffing models, but it hasn't really been a care model innovation yet. And I think what we're all hoping, I know within the subcommittee and within the society as a whole, is can we transform hospital medicine or allow hospital medicine to be a vehicle that actually becomes a care model innovation instead of merely a staffing model innovation. So again, context. Here's the pickle that we're in over the last 15, 20 years of hospital medicine's existence is we've kind of, we physicians, we hospitalists, because of the way we assign ourselves to patients, have sort of really ended up with this asynchronous care that we've forced not only upon ourselves, rounding on patients mostly alone, because our patients are scattered all over the hospital, but we're forcing that asynchronous care on our patients and their families and our nursing colleagues and our allied health colleagues. Because we assign ourselves to patients a particular way, whether it's by load balancing or call schedules or, hey, I'm the person who admitted the patient from the ED, so I'm going to go care for them wherever they may end up. We do some fairly physician-centric decisions upstream that have this downstream consequence of asynchronous care. And certainly if you've already drunk the Kool-Aid on geographic units, you're recognizing that that's our lesion. That is our lesion, and that we should be doing something that looks a little bit more like this. We should figure out a way to get into the room, to be at the bedside together with our nursing staff, who, by the way, are already unit-based. The nursing world figured out a long time ago that it makes sense to come to work and see patients on a single unit, and I think we are really just figuring that out ourselves as hospitalists. So this is, bedside rounds, at least sort of a naked version of it, in a non-teaching environment. Here it is on the next slide, synchronized hospital care in a teaching environment. Really, again, you just need to have a patient in a bed and a nurse and a lead provider. Those are the key ingredients. And this is actually what we, about 5 years ago, I think it was actually February 2010, we started piloting this at Emory University Hospital. And this is actually what we did. We all got in the room together, and there was sort of this collective, well, now what? Feeling that a lot of us had on that first day. And so by the end of the first week, we'd actually gone back to the drawing board and came back with something that looked a little bit more like this. That's a big change in a week's period of time. What we actually ended up doing, and this is a really important point for this webinar today, is we drew lines off of folks and really represented in box format who says what and when and in what sequence. Oh, and roughly how much time you have to say it. This actually got us a lot closer to being able to run interdisciplinary rounding at the bedside in an efficient and a much more effective way. In fact, this diagram, we call it a cyber diagram, this becomes our shared mental model. Right? We can take this diagram literally and we can pass it out to any new intern or medical student or a float nurse or a new hire for our hospital medicine group. You can pass this diagram out and you can sit with that person for a few minutes and they will begin to absorb it and figure out rather quickly where they are in this diagram and what their role is. So this shared mental model for interdisciplinary rounds, the equivalent of a cyber diagram, is really important to have if you're going to hope to get everybody on the same sheet of music. Now, the second obstacle to having interdisciplinary bedside rounds, and I've sort of already alluded to it, is not having a standard communication protocol. So what we've done with, say, cyber is we've got these 6 steps, and I'll spend more time a little bit later going through each one of them just to sort of explode them and make them more obvious to you. But this not having a standardized communication protocol just makes for the possibility of chaos when you all get into the room, if you get in the room in that format. So this is a really important thing to have. And I'm going to call attention to a few things that happen in the unfolding of the standard communication protocol in bedside rounds that are, I think, massive value adds and probably go a long way towards why you on this webinar today are even interested in bedside rounds. So the first thing that happens that wouldn't happen if we weren't at the bedside is something that Emily Patterson, a human factors engineer in Ohio, calls collaborative cross-checking. So collaborative cross-checking, you probably already know what it means, but the definition roughly sounds a little bit like this. It's when people, 2 or more people with different perspectives on a single thing share those perspectives in order to gain a better sense of the truth, more accuracy. And collaborative cross-checking happens as a byproduct of being at the bedside, especially if you foster it. So right here between steps 2 and 3, when the physician role is updating the hospital course, and then in item 2C, they're inviting inputs from the patient and the family, and then the nurse, somewhere in here, you're going to invite inputs, the hospitalist will, from the patient, the family, and the nurse. And as you're moving into steps 4, you've actually had a chance to corroborate or collaboratively cross-check what everybody else is saying. And it's stating the obvious, but no one person in this room has a comprehensive view of this human being in this bed. There's so much information to glean from everybody else, and the collaborative cross-checking piece is, I think, a big motivator, and it's a big byproduct of being at the bedside. What we've also built into our version of interdisciplinary rounds at the bedside cyber, which I recommend anybody do, is build in the quality safety checklist. We know that there's some completely predictable and mostly preventable complications of being in the hospital, and so let's make sure that we're not neglecting to address those items on a daily basis. It really takes just a matter of seconds for the nurse to run down the quality safety checklist. On a typical medical patient population, you're going to have Foley catheters and central line VT prophylaxis, skin integrity, and perhaps hypo and hypoglycemia on your checklist. There may be other things. You may want to prioritize telemetry and remove something else, but you're going to want to have a 3 to 5 item quality safety checklist in your communication protocol. And it does not take a lot of time to address it, and you accomplish just so much by having that proactive approach to patient safety. Something else that happens at the bedside when we're there together is something that Artman calls cognitive empathy. So again, loosely defined here, cognitive empathy is the ability of a team member to recognize that another team member has a need and then to take action to resolve that need without being told to do so. It's something that especially, again, like collaborative cross-checking, if you foster it, if you actually talk about it as an entity and coach yourself and your teammates around it, you can create all kinds of new behaviors, or you can catalyze all kinds of new behaviors in folks that have a really profound effect on changing culture. Here's just a couple examples. So let's say that we've got cyber is in its second or third minute here. The nurse is talking. Her phone rings, right? Maybe she's carrying a phone. Her phone rings while she's speaking. What do? We just stand around and let that ring, and she goes to the corner and answers it? Is she forced to ignore the phone call? Or does somebody step up at the moment they hear her phone ring, take it from her, or allow her to hand it to them, and then walk out of the room and answer for the nurse politely, take a message, and come back in the room? Any number of people standing around can do that. Probably not a great idea if the lead provider does it, because then all of a sudden that person's MIA. But you get the idea around cognitive empathy, an important thing to think about, trying to pick up during bedside rounds. And then, again, sort of getting towards the obvious, by the end of interdisciplinary rounds, by the end of cyber, we've created and synthesized an interdisciplinary plan of care. And not just a plan for the day, but a plan for discharge. Again, we'll see a little bit more of that just a little bit later. So to pause right there and sort of identify in this slide 2 of the 3 common obstacles to implementing interdisciplinary bedside rounds, it's the absence of having a shared mental model for teamwork and not having this cyber diagram. And specifically, obstacle 2 is not having a standardized communication protocol that everybody really needs to learn and adhere to in the unfolding of cyber. So there's this third obstacle to really not launching cyber but maintaining it, which is not only doing this activity but doing it really well. So it's one thing to come in the room and sort of do what you think is high-performance bedside rounding and communication. It's another thing altogether to come in there and do it at an all-star level that is recognized by everybody else in the room as all-star, not just your version of it, because we all have blind spots, but a version that many other people have sort of agreed upon as being all-star or high-grade level cyber. And so we've created a cyber certification program that teaches 20 specific high-performance behaviors for a provider and another 20 high-performance behaviors for a nurse. And when they learn these behaviors, they can practice them every day, and they can actually even recognize them in one another. So those are 3, in that one slide, 3 obstacles to really good interdisciplinary rounds, really efficient interdisciplinary rounds that you can address if you think about it. Now, the other learning objective for the webinar today was to be able to describe 4 features of this version of interdisciplinary bedside round cyber. And so the first feature of it, which is I think quite self-evident, is the location. So it does not happen in a conference room, and there's actually some folks in Europe who are experimenting with bringing patients into a conference room, shuttling them from the bed to the conference room where the care team sits around the table and waits for patients to come and go. You know, you could tell yourself that's patient-centric, or you could tell yourself that's actually not so patient-centric. But we think that rounds interdisciplinary with the patient should be at the bedside, don't we? The second key feature of cyber is the time component. And when we say the time component, we really are saying 2 things. We're saying consistent start time, and we're saying time delimited, ideally less than 60 minutes. So I'll come back to the 60 minutes thing in just a second, but let's talk about the consistent start time. One of the things we found in it is that trying to execute interdisciplinary bedside rounds without adhering to a consistent start time will tend to let old authority gradients get in the way. And I think you know exactly what I mean. Physicians will tend to delay cyber if it's not convenient for them. They may cancel it altogether, and that has a really erosive effect on everybody else. The charge nurse who's functioning as a cyber rounds manager, it has an erosive force on the nurse who's worked pretty hard to get prepared for the start of cyber, and the entire nursing staff of the unit. It's really important to adhere to a consistent start time, and hospitalists, physicians in general need to understand that they are probably the greatest risk factor for it starting late. when we teach, when we do our nonprofit work and go out and talk to hospitals about, and talk to nursing staffs about how to make this care model come to life, we really encourage them to, nurses that is, to not let physicians get away with starting even a minute late. So the second component of the time is the elapsed time. Ideally, we're doing our rounds in the morning, not so early that we haven't had time to do our primary data gathering as nurses and as physicians or as pharmacists and discharge planning professionals, and not so late in the day that we sort of missed a chance to really get some things going. So mid-morning and late morning are really great start times, but we've got a lot of other things we got to do, from calling consults, having family meetings, writing notes, going to conferences, committee meetings. So we think, in general, we've been 60 minutes is about as long as we want to allocate to the entire cyber rounds. It sounds a little arbitrary, and it kind of is, but it also, over the last 5 years, appears to work quite well. So the third key feature of cyber is the management of it. And what we mean by that is we've got the charge nurse functioning as the cyber rounds manager. That means that they're calling ahead to the next nurse to make sure that the next nurse is ready for the team of physicians and maybe some allied health professionals when they arrive at the bedside. You're not going to run good rounds if the team is looking around for the next nurse. You'll actually begin to stamp your feet. You'll grow impatient. You may be massively motivated to have interdisciplinary rounds happen. But if you can't find the next nurse, your own belief in this is going to begin to fade itself. So we've found, and we sort of learned this lesson the very first week, is we really need to have a cyber rounds manager to make sure the next nurse is waiting. The fourth feature of cyber, here's where this presentation is going to become a little bit redundant, but also a little bit more of a deep dive, is the standard communication protocol itself, those 6 steps. And so I promised earlier that we'd sort of zoom in and look at the 6 steps, and we'll do that now. So the first 2 steps are taken by the lead provider. So in a teaching environment, that could be the M3, it could be an M4, it could be an intern. In a non-teaching environment, it could be a PA, it could be a nurse practitioner, it could be the attending physician. But the lead provider does the introduction and then the update of the hospital course. The introduction takes all of about 15 seconds. You're leading the team into the room, greeting the patient and the family, and you're saying your name and the name of the nurse, and not necessarily the name of every other team member. Probably not necessary to name everybody. But name yourself and make sure you name your nurse. Claim credit for all the other disciplines in the room by saying the roles of those team members. And then the second bit, the rest of the minute, updating the hospital course, is the physician, right, sharing the information that they know better than anybody else in the room. It's the review of the active problems, it's the response to treatment so far, a very brief discussion of interval test results, or what consultants have written in their notes, or called or met up with us face-to-face to share. It's a carrying forward of that interval data. And then there's a pause at item 2C where you invite inputs from the patient and the family before then turning cyber over to the bedside nurse to do steps 3 and 4. So the nurse is ready for that. They know it's coming, and they step up when it's their time, especially in a practice environment. And what we ask the nurse to do with steps 3 and 4, what the nurses are prepared to do with steps 3 and 4 is first update the current status. That's overnight events. What's the patient's goal for the day? Have there been any abnormal vital signs or uncontrolled pain? Any concerns around fluid or food intake? Any concerns around urine or bowel input? You're going to want to create some definitions around that, some specs for your nursing staff, or help them get some specs around that so that they're able to report by deviation only. Then any abnormal mental status changes, any problems with ADLs that they've heard from the patient care technician. That's the bulk of their minute. And then the period at the end of their paragraph, the way the nurse is communicating that they're basically done with their portion, the last 10 to 15 seconds is a review of the quality safety checklist. Mrs. Williams, you do have a Foley catheter. It's a catheter in your bladder, which I think you no longer need. You don't have a central line to prevent blood clots. We're giving you the shot in your belly 3 times a day. you don't have any skin breakdown, and you've had 2 blood sugars that have been elevated beyond our high limit, one of 240 and one of 210, and that's something we'll probably want to address. And that's, it takes all of 15 seconds to get through that, and good for the physician if they're ready to do a call and response on each of those items and address and mitigate those quality or safety risks right then and there. And then the steps 5 and 6, I've drawn this here on this slide as it's coming off the resident. This is actually how we orient our interns. We say, look, if your resident by default is going to be prepared to do steps 5 and 6 for you, but if you as a 3rd-year student or 4th-year student, you as an intern can do this yourself, don't let your upper-level resident have this role. You just grab it. And what we find, not surprisingly, completely predictable, is our students and interns are outstanding, and they don't give it. They don't give steps 5 and 6 to the resident. It's just, I think, reassuring to know that they've got their resident behind them, and they're attending behind them. But steps 5 and 6 are about inviting inputs from allied health who happen to be present. So on weekdays, on some units, that's a social worker and a clinical pharmacist. On other units, there is no clinical pharmacist rounding with the team, and on weekends, there's neither one of those folks. But if you have an allied health professional in the room with you, this is the time to invite inputs from them. And good for you if you've already worked out ahead of time what that invitation means. So on one of our accountable care units, where we started this in Emory University Hospital, we have a pharmacist who rounds with each team. I know that's kind of an embarrassment of riches right there, but we worked out ahead of time that when we ask for the clinical pharmacist input, what that means is we want their input on those 3 items that you see in the red box. Any medication discrepancies to resolve. In other words, what do we get wrong in terms of admission med-rec that the pharmacist caught when they did their BPMH, their best possible medication history? What antimicrobials can we narrow, and what IV to PO switches are there? And that is what we mean when we turn to the clinical pharmacist and say, do you have any inputs? And they know that. And so we don't talk about pharmacokinetics. We don't talk about drug levels or drug dosing at this time. It's not like we don't talk about it at all, but this is not, we've decided that this is not the place to do that. Then we turn to, let's say, the next allied health professional and the social worker and say, do you have any inputs you'd like to share? And that social worker knows that when that question gets asked, when that invitation gets posed, specifically we're asking for what discharge needs and next site of care have we identified, and what's the anticipated date of discharge. And you on this webinar will know that that's a bidirectional set of information that the social worker or discharge planning professional and the lead physician have to be able to work out together. No one person is necessarily going to have those answers by themselves on every given day. A lot of times I as the hospitalist know that I can anticipate discharge needs and date of discharge, but I don't have a good idea about what facilities the patient's been accepted to, and so that's where the social worker can provide an update. And then the last step of cyber is step 6, synthesizing the plan using all the inputs. And so, like I said before, that's a plan for the day and a plan for discharge. And ideally, we are scribing this on a whiteboard in the room so that the night nurse can also look at it and help accomplish work that we set forward during the day. We can check things off as we accomplish them as we go. And when we come in and do cyber tomorrow, we have a good way of taking an assessment of what we have and have not accomplished. I'm going to call attention to this role. So you saw it earlier in the presentation, but if you're lucky enough to have an extra provider in the room, whether that's a trainee or a PA or a nurse practitioner, or maybe it's the attending, if this role is being taken by the advanced practice provider, is to have an active listener, somebody who hears decisions being made and can call out orders being captured and entered in real time. There's nothing like the present to take care of the works moment. Don't save it for later because there's going to be decay on actually getting it done. So if you don't have a second provider in the room, the question becomes, well, how do you capture information and then get it entered? Well, this is probably best practice. We've played around with different formats, but having a sheet of paper that's pre-printed with the room numbers, and I would have written in the patient's names. Don't worry, these are not real patients. These are actually the last names of of all the Atlanta Hawks at the moment. But I'll scribble down as I go a change of any quality safety orders to enter right after the cyber hour is done, any plan for the day orders that I need to try to get down. I'll just capture this stuff as I go, and then write it all down and batch enter it later, right after cyber's done. And then I'm just going to call attention to this role we've already identified, this cyber rounds manager, almost always the charge nurse, who is calling ahead to the next nurse to make sure that the team keeps moving efficiently through the cyber hour. I'm going to pause right here on this slide and just call attention to the time components on the far right of the screen. One of the most common questions around the care model is, you've got to be kidding me, how are you able to accomplish all this in 3 minutes? And the answer to that is quite simply, well, sometimes we don't. Quite frequently we do accomplish it in 3 minutes, especially if people come prepared and are crisp and on point and efficient, and they utilize the cyber high performance behaviors. Sometimes it takes 4 minutes, and sometimes it takes 5 minutes, and some patients take 7 or 9 or 10 minutes. But on average, if we're hitting about 3 or 4 minutes a patient, we can see 12 patients in under an hour. Cyber is not a time-dependent thing. We don't leave the room at the 3rd minute or the 4th minute. We leave the room when the plan for the day has been verbalized. So it's a time-sensitive activity, not a time-dependent one. But you're probably not doing yourself any great service if you're going to be designing and implementing your own version of interdisciplinary bedside rounds if you leave out the time component. It's critical. It forces people to come prepared, and it forces people to be concise. And those are 2 terrifically important ingredients if we're going to run effective and efficient rounds together. And so I'm going to wrap up here in just a few minutes with 2 things. One is just these are just 2 run charts. I've got much more data around outcomes from not just these 2 accountable care units, but several other from around the country, that the scope of which is sort of outside this webinar today. But I'm just going to give you the data I'm going to share today is just these 2 run charts. And what I can see is a pretty immediate and dramatic reduction in the absolute number of deaths on these 2 medical units after we implemented the geographic unit and the accountable care unit with this version of interdisciplinary bedside rounds cyber. And one of the you would naturally have a number of questions. For example, well, is this in-hospital mortality? Yes, it is. Did you just end up sending more patients to hospice? No, we didn't. In fact, there was actually a reduction in the number of patients we ended up sending to hospice in the entire first year out of after this care model was implemented, which I think represents an opportunity. But there are actually fewer patients dying in the hospital in this care model than before. And what we're seeing now from other accountable care units in other states is mortality, in-hospital mortality reductions on the order of 25 to 50%, which is a startling, staggering, nauseating figure. I think it certainly depends on the acuity and of the patient population you're looking at. If you're talking about patients in a relatively quote-unquote healthy patients in maybe an outlying community hospital where there's just maybe a lot of garden variety pneumonia and not a ton of comorbidities, it may be harder to find a mortality reduction in those types of settings. But in hospital units with sicker patient populations, the data, observational data, is beginning to look like there's actually mortality reductions with this care model. And one of the questions you would be asking yourself responsibly is, okay, if I'm going to go with that and believe that, then why would that be? And this slide is how we've begun to try to mechanistically understand what we think is happening in these geographic units, accountable care units, with this version of interdisciplinary bedside rounds cyber. And let me just walk you through it real quick. So what we see graphed here on this slippery slope of patient condition, you can think of it as clinical deterioration, is that patient that we've all had probably several times over in our careers where we don't love the way they look today. We think we've got them metastable on the unit, on the ward before kind of tucking them in and going home, and we come in the next day and are devastated to find out that they coded and died last night. Those are the patients, I think, that no longer slip beyond or slip beyond out of our grasp a lot less frequently. They don't quite make it to that steep part of the slippery slope. We know, a lot of us sort of grew up in hospital medicine in the mid-90s, the first decade of the 21st century, this second decade. And we would have concurrently recognized that we've gone from just having ACLS as the sole lone mechanism to recover clinically deteriorated patients, which means that we're very, very brittle. We're only reacting to deterioration after it's frankly made itself apparent. We've moved to rapid response systems, which this is a terrific advance, right? We're moving into an earlier period in the time opportunity continuum to rescue patients. But arguably, it's still kind of late to call a rapid response system. In many hospitals, I think this is a great move. You can have patients, you can have family members call code meds or rapid response teams, but if a family member can tell that something's not quite right, then that's still probably a bit late in the clinical deterioration on this slippery slope. If all we're doing is doing rapid response in ACLS, I would argue that we're just brittle. We're a lot more resilient if we enter the day with the foresight to try to prevent predictable adverse events. Think quality safety checklist during built into your interdisciplinary rounds communication protocol. We can overcome deficits in situation awareness with that checklist. We can overcome clinical inertia. Clinical inertia, of course, is the failure to initiate or intensify therapy when it's indicated. And, it's actually hard not to address clinical inertia when you're standing around the bedside with the patient and the family and the rest of the care team, and you're looking at the second consecutive day of blood sugars in the 200s. Where's the up titration of the insulin? And then I think this component in this resilience spectrum is awfully important and sort of comes to life on accountable care units with cyber geographic units with interdisciplinary bedside routing, and that's the coping mechanism. So we can detect and avert deterioration earlier if we happen to share the clinical workspace with our colleagues, our nurses and allied health professionals. We can overcome what some people recognize as normalization of deviance. Well, that heart rate of 115 on the second consecutive day, it's not okay to say that that's normal for her because a sinus tachycardia as an ominous sign needs to be explained. Maybe we've got the diagnosis wrong, or we've got the treatment wrong, or maybe we need to stay on top of this and give the current plan and diagnosis and treatment plan another 12 or 24 hours. But it's no longer on a, do you hear people saying, well, that's just normal for her if it's an abnormal vital sign? And then, we get a chance with diagnostic and cognitive error when we're at the bedside together every day to actually look at each other in the eye. Do we have the diagnosis right? Have we applied the right treatment to that diagnosis? Maybe we got it wrong. Let's rethink it. But when you sort of put all these things into a mix, into the microcosm of, or the clinical microsystem of a geographic unit and accountable care unit with interdisciplinary bedside rounds, I think you can begin to see mechanistically how we keep patients at a flatter part of the slippery slope. So let me stop there. It's about quarter till, and maybe let's see if we can turn it over to some questions.
Great, thank you, Jason. That was a great presentation. At this time, we will go ahead and open it up for questions. So if you do have a question, I'm going to go ahead and unmute all the lines so everyone will have the chance to ask any questions. So give me 1 second. Okay, so at this time, if you are dialed in and have entered your audio PIN, you'll be able to go ahead and ask any questions that you have. If you have not dialed your audio PIN, I'd ask that you do so now, or go ahead and put a question in the chat box. So are there any questions at this time?
Sure. Hey, hello, Jason. You guys can hear me? That was a great talk, Jason. Appreciate it. This is Jordan. One of the challenges, and I know this is to get into localization and geographic localization is sort of the key basic starter. But not even just a localization question, but have you had success with sites trying to, not being to necessarily get all hospitalist patients on one unit? That's sort of one of the struggles that we've had at our site at times. But basically, can you start a site where you can't get all your patients on one unit? And how have sites overcome that obstacle? And the localization question is another big question. Probably don't really have time for that one.
Yeah, it's a great question. So yes, you're absolutely right. It's pretty much a prerequisite. I think there may be one thread of an exception here that we can come back to, but I think basically it's a prerequisite to be able to do interdisciplinary rounds, to have to come to work as a hospitalist and have the bulk of your census, at least half, ideally 85% or more of your patients on a single unit. It would be really hard, right, to participate in interdisciplinary rounds on multiple units. Which one do you go to? You have to start to make choices if you're not basically a unit-based physician. But one of the things that we hospitalists probably need to begin to unwind is how we assign ourselves to patients. So I could turn your question around just a little bit, just tweak it a little bit, and say, what is it that defines my patients? Your question is, the way you phrase it is, how do I get all my patients onto a unit? And I think that's the way most of us phrase that question. But what if the question is actually solved by the statement, all the medical patients or some defined subset of patients on a unit become my patients? And if you sort of trace that statement back to its origins, it's how do we hospitalists assign ourselves to patients? And if we were to begin to assign ourselves to patients like as if the ward was a quote-unquote closed ICU, which is, if I'm rotating onto 6G this week, those 12 of those 24 patients belong to me by definition, because I am now a 6G physician. Then I don't have the problem of trying to get quote-unquote my patients onto my unit. The patients on that unit are my patients. Now, obviously, there's all kinds of, depending on whether or not you're in a system with a lot of private physicians and maybe multiple hospital medicine groups, that could, what I'm saying right now could be trying to make something sound more simple than it actually is. But I do think there's a lot of help we can get as in hospital medicine if we begin to just change the question a little bit. How do we assign ourselves to patients?
Great. We have one question from the chat box, and that is from Tiffany Mose. Have you seen that the geographical model had a notable impact on SIBR opposed to a traditional model?
Yeah, there have been a lot of. It's hard to actually find a dimension of life, work, cost outcomes, clinical outcomes, satisfaction outcomes, whether that's patient staff satisfaction, that are not impacted positively by working on a unit most of your day with your patients basically there. Let's just start. We can start on one end of the spectrum with just, I think, cold, hard clinical outcomes. Well, mortality appears to be lower in some of these units. Preventable complications of care, or complications of care in general, are 25% reduced in one hospital out west within the first 12 months of being in this model. That's more clinical outcome-y. But let's flip to the other end of the spectrum and just look at some more social or soft outcomes. The relational benefits that you get from being in an environment with a consistent group of nurses and allied health professionals is, I think we've been massively discounting it within our field for a while. To be able to come to work and see nurse A or nurse B or nurse C, and to know their names, their first names, not have to look at their name tags, and then to get to learn that so-and-so is just so good with the way she presents patients on cyber, or they have such a nice way to sort of diffuse tension, and you get a chance to appreciate the professionalism and skill set of nurse colleagues in a way that you just couldn't have before. And again, it's really easy to discount how important that actually ends up being in terms of how you begin to think about your work and the work we do as physicians. You really do become not only a better team member, but you realize how great a team you've got around you that you can begin to wield through your sort of de facto physician leader role. But then everything in between in terms of outcomes. Length of stay is about 10 to 15% reduced on units that pop into this model and stay in this model effectively. Patient satisfaction is higher. Nursing turnover is lower. DT prophylaxis rates are higher. Catheter days are lower. There's educational outcomes I haven't begun to talk about yet, but there's all kinds of statements that you can find from residents who rotate through units like this, not just here in Atlanta, but you can actually, if you were to go Google Providence St. Vincent's Medical Center and Accountable Care Unit, what you're going to find are some comments from some of their residents around this care model and how much they like it. In fact, their residency program has realized that this is an attractant for medical students who are looking for a residency program that trains them to do team-based care. So forgive me, that's a long-winded answer, and I was kind of all over the place. But yeah, it's hard to find a dimension of care that's not somewhere between a little bit better and a lot better.
Great, thank you. Are there any other questions? Okay, well, if there are no further questions, I'd like to thank all of you again for participating, and thank you, Dr. Stein, for... Sorry? Did someone have a question?
No, it was a pleasure. Thanks.
Yes, thank you for presenting today. We really appreciate it. As I mentioned previously as well, CME credits will be available for participating in today's webinar, and everybody that participated on today's call will be emailed once they're available. And in tune with our webinar series, the next webinar will be Wednesday, March 25th at 3 p.m. with Dr. Laura Fanucci and Dr. Sid Singh. So again, I thank you all for your time today. This webinar will be available within the next few days on the SHM e-learning portal. So if there are no further questions, thank you all again.